Good afternoon, everyone. Hello, welcome. My name is Yvette Subramanian, and I'm pleased to be able to introduce Margaret Laws, who's going to be our research exchange speaker. To remind you,
We have a soundtrack.
Okay. So to remind you that we have an Eye for Energy talk on Friday at noon that's going to be talking about the work going on in this building, CITRIS Hall, to reduce peak energy load. So there's a lot of interesting things happening there. Also, big ideas. The proposals are due on November 21st. So if you're a student with a big idea, the proposals are due on November 21st. You can watch the workshops. We had two writing workshops on how to write your proposal for this contest. They're online. They're on YouTube. I recommend you go look at them if you have any questions. And we have two special events coming up. Tomorrow we have a special lecture from IBM on building a smarter planet here in the auditorium at 10 o'clock a.m. So 10 o'clock tomorrow morning, if you'd like to join us for a talk from IBM, Dr. Bernie Meyerson will be here to talk about his work. And the holiday gala for CITRIS will be held on Wednesday, December 7th at 4 o'clock p.m. So this is our annual event just to celebrate CITRIS and what we've done this year and to help get people together and have a nice discussion and talk and party. So that'll be December 7th, and we look forward to seeing you there. So today's speaker, Margaret Laws, she is the director of the Foundation's Innovations for the Underserved program at the California Healthcare Foundation. And her program focuses on reducing barriers to efficient, affordable health care and by encouraging, testing, and promoting lower-cost models of care. So she's going to talk to us today about her work. Please join me and welcome her.
Thanks. Thank you, everybody. Is that mic good? Can everybody hear? So I want to start out today, give a little bit of an introduction to the California Healthcare Foundation, who we are, what we do, and then just talk a little bit about innovation across industries, why we're not seeing in healthcare what we're seeing in some others, talk about what we do in the Innovations for the Underserved program at the Foundation, talk through some examples of innovative technology, service, and device solutions, some of the pieces of the puzzle of innovating for lower cost care, and then talk a little bit about how we're thinking about components of an innovation ecosystem and some of the challenges and questions this work we've been doing at CHCF has raised. So just a brief overview of the California Healthcare Foundation. We're based right over in Oakland. We're a private nonprofit foundation founded in 1996 when Blue Cross of California converted from nonprofit to for-profit. We do about $35 or $40 million a year in funding of projects and grants. Almost all of this is strategic rather than unsolicited. So our board and our staff sets a set of goals, and then we go out and work with people across California and across the country, academics, nonprofits, companies, to try to meet those goals. So we don't do a lot of acceptance of unsolicited funding or research requests. We focus domestically. We're focused on improving healthcare in California. So all of the work we do has to somehow improve the health of the people of California. And we focus our work in three major areas. The program I lead, Innovations for the Underserved, works to try to dramatically reduce cost and dramatically improve access to care for underserved populations who we define as uninsured people, people on public programs like Medicaid, people who are in rural geographies or who otherwise have difficulty accessing care. Our Better Chronic Disease Care program works to try to close the gap between what we know is good practice in better chronic disease care and what's happening out there in the field, again with an emphasis on those organizations and providers who serve low-income and underserved populations. And finally, our Market and Policy Monitor group does a lot of work looking at trending and tracking in the healthcare system, health reform, what the implications will be for California. We launched the Innovations for the Underserved program in 2006 and the CHCF Health Innovation Fund, which I'll be talking about in October 2010. And just a real quick map, I think one of the things I like to help people understand about the California Healthcare Foundation is while we recognize that the healthcare landscape is broad, it includes social determinants of health, environmental health, health and wellness, our focus at CHCF is really on healthcare delivery. So we work with healthcare providers from hospitals to clinics to medical practices to health plans to try to improve healthcare delivery rather than work on the bigger environmental and social aspects around healthcare. So just backing up now for a second, I want to talk a little bit about about what we have coming as we see health reform. And I don't know how many of you remember this one, but this was the Vice President and President talking about how big a deal really is health reform. It's a big deal. And what we see coming with health reform, particularly with those organizations that serve underserved consumers, is a huge influx of a demand into a system that already really struggles to meet the demand it currently has. So just to give you a sense, in Massachusetts, when universal access, universal coverage was passed, the community health centers or clinics that see the majority of low-income people saw demand increase by about 30%. And they're already strained to meet the demand they have now. The public hospitals saw about twice the additional influx of patients that the commercial hospitals did in Massachusetts. So one of the big contextual things we think about at the foundation as we think about innovating for the underserved and innovating for lower cost care is ways to really try to improve supply to meet this demand that's out there for healthcare. So backing up, when we think about other industries, we don't do anything the same way we did it 40 or 50 years ago. Banking obviously has changed. We moved from going to see your teller to the ATM, which I remember from when I was in college, to banking online. Travel arrangements, people used to go to travel agents. Probably not many people in this room remember that. But now we book online, and there are increasingly specific ways that we can book and do things very personalized online. Research, some of you may remember the librarian. Now we have much more efficient, quicker ways to get access to the information that's out there. But medical consultation, which looked like this 40 or 50 years ago, still pretty much looks like this. We just haven't seen the same kinds of innovation being brought to bear in healthcare. And it really raises some interesting questions when we think about all of those other industries where technology is really seen as the enabler, the savior, the thing that makes us be able to do things better, faster, and cheaper. In healthcare, technology is often seen as the enemy. It's the thing that's just going to make healthcare cost more. And a lot of doctors' offices look a lot like this one with the technology infrastructure you see here. So where does that take us from our perspective as a foundation? We in the Innovations for the Underserved program really focus our efforts in two main areas. Encouraging testing and promoting lower cost models of care through a whole range of grant-funded activities that we do, through supporting of university programs in innovation, through testing new innovations out there in the field. And then second, we've launched this program-related investment fund. And this is a type of an investment fund that a foundation can launch. Several healthcare foundations around the country are following the lead of community development, environment, some of the other areas, where we thought we actually want to take some of our charitable dollars and put them not just to nonprofits and kind of the usual suspects, but think about how we can invest in companies that share our mission, the goal to dramatically reduce cost and improve access to care, but that are doing it in a company that may have the potential to be much more sustainable financially and scalable to try to meet the need rather than just in one hospital in California through a model that can scale out to hospitals around the state and across the country. So how do we go about doing that? One of the first things we do, and a big foundation of our doing this work as a healthcare foundation, is that we understand the safety net provider and payer needs and pain points. So we spend a lot of time out in the field, in clinics, in hospitals, with Medicaid plans, in the policy arena, understanding where the biggest challenges are, understanding the economics of the arenas in which people are playing, and then thinking about where there really is the incentive or the will to innovate to try to solve some of those problems. We focus on dramatic reductions in cost or dramatic improvements in access, and I'll run you through the metrics of how we think about this a little bit later. We look for solutions that are working in commercial markets or other states or other countries, and we think about how those solutions, how we might help migrate those solutions into the healthcare system in California, again, particularly into the safety net sector. Often that results in us trying to make a market between companies and safety net providers. So we spend a lot of time helping the companies understand the environment of the safety net provider and helping the safety net providers understand and trust the company. So we're really looking for people who have an interest in understanding how a Medicaid market or a market that serves underserved people works. We focus on sustainability and scalability of solutions. So we're really looking not for something that could be, great in a couple of places, but something that really has the power or the potential to scale across the state at least, and ideally across the country. And we use a range of tools. We use grants, we use debt, we use equity, and we think about what the right combination of financing is for any given project or investment. So just a few examples of some of the kinds of things we've been doing in California to date under our grant-making programs. We've done a lot of work in the area of telehealth. We've worked with the UC Berkeley School of Optometry on a major store and forward diabetic retinopathy program, more than 80,000 diabetics screened to date. We're doing a lot of teledermatology support as well. Work doing real-time video consultation to bring specialists to help both patients and primary care providers in remote areas. And virtual dental home, which is a relatively new program that's trying to bring, again, some of those telehealth technologies to get access to dental care. All of these involve a combination of often a lower cost device, in most of these cases a camera of one sort or another, a set of devices, and then a system or a service model that can actually efficiently bring these technologies out to people in the field. E-referral, an interesting program that started in San Francisco and is now being launched across LA, that's actually allowing primary care providers to do electronic referral to specialists, and again, hopefully be able to deal with as many patients as they can without referring them into a specialist queue that'll often be 6 months to a year long before they'll be able to be seen. We've sponsored development of a diagnostic kiosk, a urinary tract infection, basically kiosk that can replace a visit with a provider in an urgent care or clinic setting by putting in an interactive patient technology to help people walk through a diagnosis and support the providers to be able to see more people during the visit time. And then finally, the Healthcare Interpreter Network, a voice video interpretation network that links currently 17 hospitals in California, most of them public hospitals, to one another. They share interpreters in 15 languages plus American Sign Language. So this is one where you could be sitting in Salinas and you have a Hmong interpreter in your hospital who actually works in accounting. Someone down in LA needs a Hmong interpreter, and within 30 seconds they're connected by video and can get that interpretation done. So it's both a great use of advanced switching technology and also of the labor that already exists in these organizations to allow them to meet the linguistic needs of patients in a much more efficient way. And that's doing 100,000 plus interpretations a year now. This is just a picture of this is featuring our diabetic retinopathy site. Again, just emphasizing that we have both the Innovations for the Underserved Grant Program and the CHCF Health Innovation Fund. And then if you want to visit our site and learn a little bit more about some of the projects we funded, our Innovation Fund landing page basically walks through a page on each of these, and they range from a device that sits on top of a rescue asthma inhaler that'll date and time and location stamp where the person is having their asthma attack so that information can be aggregated and fed back to the patient and provider, to Serum, which is a technology platform that basically allows people who have excess prescription drugs, nursing homes, long-term care facilities, drug companies, to transfer those to county health clinics and others who need those drugs. To the Healthcare Interpreter Network, which I just talked about, we'll be putting a couple of new ones up there, but that'll give you a sense more specifically some of the things we've invested in. So why did we go down this investment route? I've been at the foundation now 13 years and have done a range of things there, but have consistently run into the challenge of taking a really great program, a program that keeps kids with asthma out of the emergency room, a program that can get retinopathy screening to hundreds of thousands of people across the state, that after the period of the grant is over isn't sustained, no matter how exciting the results were, and can't scale. And a big part of the reason for that is that those were not set up as companies that had a goal of sustaining and scaling. They were set up to basically have a goal of demonstrating that they could achieve this. Goal. So it's a frustration a lot of foundations feel. Going to funding for-profits or revenue-generating nonprofits is not the complete answer, but we think that for a lot of these innovations to scale, they're going to need to be housed in an organization that's operating more like a for-profit that has sustainability goals and spread and scale goals. We were starting to see a lot of companies come to us and say, we're very aligned with your mission of lowering cost and improving access to care. We'd love to work with you. And we really didn't have a financial mechanism for doing that. And then finally, an interesting movement, and you'll see this as you go out and look for funding for projects you're working on, among foundations and social investors, to try to take more of the asset base and get it aligned with the mission they're trying to achieve. And so there's a huge amount of money sitting in foundation endowments, and these investment funds give foundations a way to get some more of those assets targeted towards things that are tightly aligned with their mission. So what do we support through the Innovation Fund? We're looking for sustainable, scalable organizations and companies with products and services that can lower costs and improve access on the Innovation Fund side. And then through grants and partnerships, we're focusing on trying to cultivate an environment and work with innovators to get some of the most promising young innovators, many of whom are here in California, many of whom are here on this campus, to focus on lower cost in the U.S. healthcare system. A lot of places we go, you either work in the commercial healthcare system domestically, or if you want to do good, you go work abroad somewhere. And what we're trying to do is talk with innovators who are working in these programs and give them opportunities to go into low-resource settings domestically and understand what some of the needs and challenges of those low-resource settings is, and innovate to try to meet those needs and challenges. So we're working with university and other innovation centers, directly with entrepreneurs through a number of channels, other foundations and social investors, and then an important part that we try to bring as a foundation, working with policymakers to try to identify barriers to spread and sustainability of innovation, or even to be able to get an innovative idea tested out there in the field. We have a fund of $10 million to invest over 3 years. We're just a year in. Over a total of what will probably be more like 8 to 10 companies and organizations. And the criteria we're looking for are obviously strategic alignment, first and foremost, a very clear connection to our mission. The second is significant impact, which we defined, and it's a difficult thing to pin down, not that scientific, as the potential to impact 100,000 Californians, provide new access for 100,000 people in California. The retinopathy program would be an example of that. Or to deliver $25 million in annual cost savings for a defined population, either a little bit for lots of people or a lot for a smaller group of people. Scale and sustainability, business models that show potential for significant growth and scale, and an experienced management team, CEO and team with a proven track record or with the ability to bring in that kind of a person. Total investment of about $3 million over the life of the company, and then preference for capital-efficient business models. So we're not in pharma, we're not in therapeutics, where you need a lot more than $15 million to get to market. So that's where we've initially targeted our innovation fund. We're looking at revenue-generating nonprofits. We're looking at for-profits that are too early, too risky, or addressing too small a market for traditional financial investors. Or we're actually working with financial investors, venture capitalists and others, to take an investor-backed company that we think has real promise for an underserved market into Medicaid or into a rural geography or into California. So we're looking for opportunities to partner with companies that have demonstrated success in the commercial market, but think that they also, and we believe that they also, have the potential to have a big impact in an underserved market. And we use, as I said before, recoverable grants, debt, and equity. So our sourcing strategies to date, we've had and still have an open call for applications. We have a platform that's an angel, it's now called GUST, that's an angel investment platform where people can come and put their business plan in and apply. We then screen those to see if they meet our criteria of strategic fit and impact, team, et cetera. We've done very broad outreach to relevant venture capitalists and angel networks to really help them understand what we're trying to do, to find people who are also interested in and share the mission of CHCF and have companies they think really could have a big impact on lower costs and improved access. We're looking for companies that want to move into a Medicaid market or into a rural market and have seen some very interesting ones in this category. They often say, look, we just don't understand these markets. If you can help us with that translation, it's something we're very interested in testing. And then finally, we've been working with other foundations and other social investors who've been doing program-related investment to share information and referrals. So if we get a really interesting opportunity that is primarily international or is primarily about health and wellness, we'll go out to our network of other health foundations and say, you know, we saw something out in California that's really interesting, not a fit for us, but it seems like it might be a great fit for you. Will you guys take a look at it? So we've been trying from CHCF to try to cultivate a broad group of healthcare foundations, again, some of which have both international and domestic focus, many of which have just domestic, but work in different parts of the healthcare ecosystem to share some of these opportunities. So how do we try to add value? How would we play a role as a partner in one of these investments? We have very, very broad exposure to the markets, hospitals, health plans, clinics, medical groups that people are trying to reach. So we can get out and help people get in front of potential clients who can then give some really honest early feedback. This is what this would have to this is what this would have to do for it to make sense for us. These are the kind of numbers it would have to hit, et cetera. These are the features it would have to have. It would need to be in Spanish. It would need to be at a 5th grade reading level, some of the things that come up. A strong understanding of the policy and regulatory environment. So we spend a lot of time with folks in Sacramento and to a lesser extent Washington, but particularly for policy and regulatory issues at the state level, really being both helping people understand the policy environment, but also in many cases helping move the policy environment to accommodate the needs of these innovative companies that are using technology in new ways, that have people working in different places, you know, providing care from a distance. One of the things that we did this past year, we have an organization in Sacramento, the Center for Connected Health Policy, that brought together a group from around the state, a model telehealth working group that basically brought together providers, policymakers, you know, both parties, all persuasions, to talk about what is the policy environment and the platform that we need for technology-enabled care. What are the things that using technology to try to make care more accessible and available is raising in terms of these new business models or new technology models? So just a very simple example is that Medicaid, Medi-Cal, one of the big payers in California, wouldn't pay for a provider, a specialist, if he or she was providing care from his or her home rather than from a doctor's office. And a lot of the excess supply, if you can call it that, or the potential supply, is people who are willing to do some work moonlighting, who are partially retired. So getting a barrier like that out of the way is a really important one for a lot of these technology-enabled companies to be able to have a market and to have a business model that doesn't have so much overhead that you're creating, by definition, a high-cost model. And I think really for some of this telehealth and distance health provision, the only way it can be offered at low cost is if you take out the overhead of someone sitting in a UC office with all of the attendant financing that goes around that. And finally, we, as I said just a moment ago, we talk about collaboration and syndication opportunities with other social investors. So we're out there looking for the investor that is the right fit for this company, whether it's one that's in our wheelhouse or not. Just a real quick overview before I jump into some of the specific companies about what some others out there who are social investors are doing. Robert Wood Johnson Foundation has a $100 million PRA fund, and they've done quite a bit of funding in areas of data aggregation and use, the Archimedes Project. Project ECHO is a program that brings specialists to providers in remote areas. It started with hepatitis C, and it's now in about 15 different specialties started at the University of New Mexico. They're now working on spreading that across the country. The Lemelson Foundation in Oregon has a recognition and mentoring program, the RAMP program, that focuses on young inventors, and everywhere from middle school, high school, up through. And this is a foundation and a program that really focuses on very early stage innovation and invention. The Acumen Fund has been historically only international, is now looking at doing a domestic fund, focusing on what they call patient capital. So investing with longer time horizons and capital that is lower interest and longer time horizons to try to accommodate some innovations that may serve markets that aren't quite as lucrative. The West Health Institute down in San Diego has launched the West Health Innovation Fund, $100 million. Previously, the West Wireless Fund, so a lot of their focus has been historically on wireless applications, that has just announced a $100 million fund where they also have mentoring, an R&D lab on site, support. So they're looking for both more mature and earlier stage companies that they can bring in and nurture. And finally, just again to go into a different area of health, the California Endowment put together the FreshWorks Fund, which is basically a fund that brings fresh food grocery stores into low-income neighborhoods that don't have those. So it provides capital that will bring a financial investor in to try to de-risk that a little bit, to bring fresh food and work on health and wellness in low-income communities. So now shifting over a little bit, when we talk about innovating to lower cost, conceptually, what are some of the things we're talking about? We're thinking about devices, technologies, and services that allow care to be delivered in lower cost settings of care or by lower cost personnel. So really thinking as we walk through this, what are the different ways you could innovate that would lower cost or bring cost down in the healthcare system? Taking it down all the way to the patient's home in many cases is one of them. Thinking about technology and service models to extend provider capacity. So the telehealth models that I've been talking about can take one provider who previously could only see as many patients as he or she could get into the office for those scheduled blocks of time, can now actually look at pictures and provide diagnostics, or can see patients off hours. So thinking about how to take the limited pool of providers and extend it. A lot of opportunities in improved infrastructure efficiency. And then one of the other important ways I think that the information and data availability and processing capabilities we have that we haven't had before, allowing price transparency for consumers in ways that we haven't seen it historically. So what I'm going to do is just walk through some companies that I think are examples of some of these concepts for lowering costs. And the first one is a company called Polyremedy. And I sort of talk about this as a company that uses technology to upskill workers. And what this company does is it has created an evidence-based platform. So you have a set of questions that if you're providing wound care and you're a well-trained wound care specialist, this is the series of questions and observations that you're going to make. And you make this available to a home care worker who typically is not going to have a lot of training. He or she is not going to be a wound specialist. They're going to go out to the patient's home, and they're going to go to the back of their trunk and put together whatever bandage they can and hope that it works. So what this does instead is it gives the person on any kind of a portable device, any kind of a PDA or iPad, tablet device, an assessment tool. When the person has assessed the wound, it then sends that data back to basically wirelessly back to a factory. A personalized dressing is sent out by FedEx that says, Mr. Jones, change Tuesday, Mr. Jones, change Thursday. So what you're effectively allowing the person to do is either the caretaker in the home or the home health worker is now applying evidence-based care and treatment where she just wouldn't have had the skills to do that otherwise. It also has the great feature, which the normal way of doing this does not, of tracking that data and being able to provide information about how wounds are healing, how different people are performing. So a really interesting way of taking technology, putting it in the hands of someone, and by virtue of doing that, giving them a skill level that they wouldn't have had otherwise, and allowing people to get high quality wound care in a less costly setting. I don't know how many of you have seen this. It's called a live core. It's gotten a couple rounds of funding recently, so you may have seen the announcement. It's basically an iPhone ECG that's going to come out in the U.S. market at under $100. So the form factor it takes is either a case for an iPhone, where the technology is embedded in the case, or a card that you can put up against any of the other form factors. And it basically turns that device into a single lead ECG. And we think about this being interesting in lots of different settings, from people who are doing mobile health work, to even a heart patient in the home, where we want to have more accurate and more continuous or more regular monitoring. Telehealth for improved access, I've talked about this quite a bit. This is basically a company, Direct Dermatology, that is a couple of Stanford dermatologists started. They're providing dermatology consults, again, via teledermatology, images and responses to those images. And they've started with a market of clinics that serve low-income people in the Central Valley, but are now expanding this program. And again, the hallmarks of this are they've been able to set this up as a low-overhead business. They're able to do high volume because they're working primarily off of all off of images. And the programs that we funded historically, with a teledermatology consult, you're able to actually resolve better than 90% of conditions in a primary care setting. So you're doing two things. You're not sending people to a dermatologist if you don't need to. And in the cases of the low-income populations in California we work with, you're not sending somebody with a dermatology condition into a 6-month waiting line where, in the next 6 months, either things are going to continue to get worse or they'll resolve. But you're basically giving them an immediate solution to their problem. Redistributing unused medications. I talked about this one a little bit before. This is serum. And this was developed both as a environmental play, not putting all of this medicine into the waste stream, but also for the billions of dollars of medicine that's destroyed every year, getting that to places where people really need that medicine. And they basically pulled together a policy change, which was a Good Samaritan law that enabled the movement of drugs that had already been paid for in one place to another place, along with a technology platform that's like an eBay or a Match.com, think of it how you will, that matches up demand with supply. And this is a demand-driven program. So they go out to clinics around the state and say, what do you need? And then the system goes out and looks for those drugs. And to date, it's in 3 counties and has about 70 or 80 donor organizations in California. And they're looking to expand that. And what's been interesting about this one is that one of the things it has resulted in is getting a lot of high-value drugs, often psychiatric medications, that the safety net systems have a very difficult time getting access to and getting those into the hands of those providers. IT and infrastructure efficiency is a big one. And if you think about all of the small providers, from small hospitals all over a state like California, where you've got lots of small organizations, hospitals and clinics around the state who, A, don't have access to the IT talent that they need, and B, it just does not make sense to have these systems replicated at every single site around the state. We're starting to see these solutions. This ClearData happens to be one that basically takes the IT, both hosting and reporting challenges from a small hospital, a rural hospital, and manages those for significantly 30 to 40% minimum, less cost than it would cost them to do it on their own site. This is a company called Frisia, and this is actually an interesting one, again, highlighting how little technology and how little use of technology we see in a lot of healthcare. This is actually a tablet for check-in for a physician's office. So probably most of you, when you go to the physician's office, you fill something out on a clipboard still, I'm guessing. And that's the way it is in most offices. This instead gives you a tablet. You can see that there's a swipe card for credit card collections, so it's efficient for them, both in terms of getting the copay collections, but also in doing two things. One, keeping that data so that the next time you come in, all you have to do is say, this is Margaret, I'm here, and it's asking me only the questions I need for today rather than all of those demographic questions over again. But it also gives you the opportunity, and you could think of this for good purposes or bad, of serving up to that person information that's helpful to them based upon things they put in. I'm a certain age, make sure you get these screenings. I have this condition, think about this drug. So we've actually used this in the urgent care center at UCSF for both the UTI module, we moved it from a kiosk onto this, and then to ask people to try to get better compliance with screening, so chlamydia screening, various STD screenings, but also just health education. So just thinking about the utility of a tool like this, I guess it was voted the coolest product, so that's good. But all the different things you can do once you have some information about a person that can enhance that visit. Okay, finally, on to price transparency for consumers. This is a company I was just talking to again this morning. And this is a company, GoodRX. It was started, you'll see the similarity. It was started by one of the early Google guys. And it has a very clean Google interface. And basically googly interface. What you do here is you go on looking for where to get the best price on your drug. So you put in the drug name. I'm in San Francisco, California. And let's say that I was looking for Lipitor. I can set my distance. I'm looking for the best price for Lipitor within 5 miles. And what this shows you, and this one actually isn't one of the more dramatic, it's not one of the most dramatic examples. I wanted to use a very common drug. But it shows you something that you hear about, but that you've got really, really dramatic differences in price from site to site. So this is actually a data company. It's a company that the real challenge of bringing this product to the market is having the data feeds on all of these different sites for drugs, and then integrating that, as they will do, with information about what your benefits offer you. So this is, again, just an example, I think, both really of how the changes that we've seen in the ability to get and process data have allowed us to offer people in transparency and information that can help them make better decisions, both at the employer level and at the consumer level. This is another company that some of you may be familiar with, got a lot of investment. Castlight takes the same concept and actually takes it out to all different aspects of healthcare. So this is the notion that if you're doing anything elective, you can find what the options are. You want to get a hip replacement, you need to have some sort of a procedure done. You can get information. And what Castlight will say is that the amount that common healthcare service prices vary, 704%. So you could see a little bit of an example of that with the drug prices. And when you take that out into the market and you begin to make transparent what different places are charging, things that we just haven't ever been able to know before, you can allow consumers and allow employers who are paying for a lot of the healthcare for their consumers to actually make more informed decisions that hopefully for all of us will drive prices down. And then I just put one up here because this is something else we've done at the foundation that I think is sort of an interesting one. This is a project called Enroll UX. And so in 2014, when everybody has to enroll in health insurance exchange, what will that user experience be like? And this is basically creating a front end or a user experience to help people understand what their coverage options are and connect with that coverage. And we are leading this with about 7 foundations around the country, as well as the feds and a number of states, to really try to help people have a way of getting information about their health coverage options that will allow them to make the choices that are right for them. So when we think about the challenges of those are some examples of companies that we've been looking at, and we've been thinking, how can we get those out in California? How do we get those out to the healthcare safety net? We're thinking about, what is the ecosystem for innovation in California? Lots of R&D funding, policy and implementation laboratories all over the state, including right here. thinking about where support comes at different stages. How do we help a company that's just at an idea stage find support it needs? How do we help a company that's ready for growth find the right financing? We spend a lot of time, as I said, exposing innovators to safety net needs. So getting people who are, enthusiastic innovators who are interested in going to San Francisco General Hospital or to the clinic down the street and really looking at what the challenges are in those places. And then exposing the safety net to innovation. A lot of the safety net organizations we work with are not afraid of innovation, but are not that open to having outside companies come in, afraid of losing control. So thinking about that, we've sort of been thinking about this more as an ecosystem where we've got sources of innovation from the international systems, VC firms, systems across the U.S. like Ascension, CHW, and Kaiser, places like the UC's CITRIS, QB3, Stanford Biodesign, who we've worked closely with, healthcare incubators. We've got a series of policy partners from the Center for Connected Health Policy, the California Telehealth Network, the mHealth Alliance that's focusing on mobile health and the regulatory and other innovation challenges there. And then innovation test beds. Where do we actually find providers who are interested in testing some of these innovations? So we're working with public, rural, and critical access hospitals, with community health centers and clinics, with Medicaid managed care plans, consumer organizations, and then employers and unions. So we're trying to just play a role in creating the necessary matchmaking to put together an innovative company, early stage company or idea with the right partners to try to take it to the next stage and test to see whether it's something that can really provide value in California. One of the things that we've done is in our early stages is funded some incubator and competition efforts. So we worked with the William von Liebig Center down at UCSD. It's a center that works to try to take technologies invented in universities, so by university faculty and student teams, and bring those to commercialization. Spends a year with them and puts $100,000 into taking them from the laboratory out into commercialization through IP, through legal, through testing out in the market. So that's something that we sponsored down south with the Von Liebig Center. We're looking for opportunities to do that across the state. There are other competitions and incubators, some of which you all may be familiar with, that we've participated in. Rock Health is one that's focused on really consumer mobile and consumer applications, really more apps that can improve healthcare. HealthBox out of Sandbox Ventures in Chicago is running the HealthBox Accelerator, again taking early stage companies and giving them mentoring and support inside a venture firm to try to get them launched. Blueprint Health in New York doing the same thing. And then, as I described, the Von Liebig Center. And these are just a handful. These are a few that we've supported in our first year of doing this, but there are many, many more. And really focused, we're starting to see actually at least one of these, the CellScope otoscope came through one of these that was developed in CITRIS. So just sort of tying up, thinking about the innovation environment as we've looked at it both through our grant making and through this investment over the past year. What are we seeing? Technology is maturing. The California Telehealth Network has brought high-speed broadband to sites in rural areas all over the state, and it's made it possible for a lot of these organizations to use technologies they haven't been able to before. The cloud, obviously, is allowing a lot of the IT infrastructure plays that we're seeing. Low development costs for mobile and apps, so we're seeing a huge explosion of people developing apps. I think the real challenge is how do we connect those to the healthcare system. EHR implementation, electronic health records as a platform for a lot of these technologies will make them much easier to integrate. Policy is evolving. This year, the Telehealth Act was signed that really opened up a lot of the technology-enabled care platform in California. But I think it's just really important to note that the implementation challenges are still really significant. There's a huge culture issue. Not invented here, won't work for our customers. We need to build it ourselves. Even if we do it inefficiently, we need to control it and own it. So thinking about the willingness of these organizations to partner with and absorb innovation is still, I think, one of the biggest challenges we face. And then integrating with electronic health record. Many of the safety net organizations in California and around the country are just in the process right now, or healthcare organizations, period, are just in the process right now of getting electronic health records up. And because so many of these need to integrate with the data or be at least interoperable with it, it's a huge challenge in working with any of the organizations in the U.S. right now. So what do we see as some of the biggest opportunities? Obviously, controlled or lower cost. We really try to focus on convenience for patients. I think it's really important, and our healthcare system has really overlooked it. So a lot of the things that have come out that make things more convenient for patients, allow them to do things from home, I think are important. Improve quality, and then using these technologies for rapid learning or upskilling of both providers and patients. And some of the biggest challenges, as I just described, not invented here, whether it's a big healthcare system or a small safety net provider, there's a skepticism about taking in innovation from the outside. Obviously, the second big one, how do we pay for it? We're already overstrapped. It's tough for us to bet on savings that come down the road. Where we can't take it off our top line, it's hard for us to support it. So getting people to bet on something that helps manage chronic disease care is not easy. And then finally, will the provider, how do we support it from an IT perspective, a big issue? And then finally, will providers and consumers use it? So as we go out and look at these technologies and think about how to get them out in the market, these are some of the challenges that we're exploring. And with that, happy to take questions.
So do we have any questions? You have a question?
In the UK, they have a third alternative to treatment for anxiety and depression. So in this country, we have drugs and therapy. There they have drugs and therapy. And they have a computer game that they've had. Do you know about it?
I do.
And you know that there's a free version in Australia.
Yep.
And do you know that the UK's FDA has reviewed Mood Gym in Australia and said it could be better than the one we're paying big bucks for? Mm-hmm. The free one might be better than the expensive one.
So
yes, that was a yes/no question.
Was that the question? So
yes. Do you know that the UK FDA reviewed the Australian one and said it could be better than the one we're paying big bucks for?
I didn't. We have been looking at that space, at the cognitive behavioral therapy, basically online cognitive behavioral therapy, but I wasn't aware that that was the case, so we'll look into that as we think about how it might play out here.
We have a question back here.
You talked about more efficient use of providers' time. For example, with a dermatologist, instead of seeing one patient every 15 minutes, they might look at a series of pictures, maybe one every minute or so. Do you see a problem with burnout? Is there resistance to losing the people contact? And how is that working out in practical world?
Most of the people we're working with who are doing it still have a mix of doing the virtual and the in-person practice, and there's also people who are in situations where doing practice from their home or doing practice part-time using this technology approach is a nice thing for the stage of their life they're in. But I think it's a huge concern, and when we talk with organizations who are doing it, even if you think about something like putting nurses out in a minute clinic or a express clinic rather than having them in the main practice, most of the organizations we work with want to rotate the people because they want to keep them connected to both everything they can get from their colleagues at the mothership as well as the opportunity to be out more remote.
So we have a question here.
The Health Care Act has a large focus on innovation and assumes that there will be significant cost savings from innovation. How is the Health Care Act going to change the innovation ecosystem? What should be the role of government, and is this going to work?
Well, it's interesting. I don't know if you saw this, but yesterday, CMMI, which is the Centers for Medicaid and Medicare Innovation, announced a $1 billion innovation fund. And they have $12 billion in an innovation fund in Washington. And, it has been slow and bureaucratic to get going. And it was an exciting announcement that they made yesterday where they're actually taking applications from the states. I think that when I think about it and I think about CMS as the main regulator in DC and the Medicaid agencies or the healthcare agencies in the states, there's going to have to be some willingness to test and try things and open up if we're going to really save cost and make progress. And so I think there's a lot of fear of using new technologies to deliver care, that it will open the floodgates and you'll suddenly have lots more people and you're not going to see those cost savings down the road. So I think that really what's going to happen is there's going to have to be some rapid kind of fast failure learning about what's actually helping to reduce cost and what's not. But I think without the federal government thinking about the regulatory environment and thinking about things like letting a patient be cared for in the home rather than in a higher cost setting, it's going to be difficult to realize cost savings.
Yeah, I'm wondering how helpful it really is for the consumer to be able to find out what the retail price of a drug or a service is. I guess the question is, what percentage of patients are currently in a health plan that has negotiated a price or limited their choice so that this isn't really a useful service for them?
Well, so the way this actually plays out, there's two answers to the question, and one is there are a lot of people who don't have anybody negotiating for them. So if they're paying out of pocket or they have a very high deductible health plan, they're paying the retail price. So there's that group. Put them aside for a second. Within the employer group, what this particular service can do is take the benefit structure that the patient has and compare prices given that benefit structure. So if you think about the employer and the consumer, and you think that the consumer might make a choice of a brand drug versus a generic drug, this helps make it transparent. You might make that choice, but this is the difference, and somebody's going to pay that difference. So in a lot of cases, it has to be a combination of the payer, whether that's a health plan or the employer, and the consumer, and they both have to have that information, and they both have to be able to make decisions based on it. So a lot of it is really about presenting to people options. You can have this option and pay $10, or you can have this option and it's free, to try to get people to move towards using generics or using lower cost drug options. Recognizing that they're not for everybody, and so people want to leave people the freedom. If you want to pay for this, you can pay for it, but it's going to cost you a lot more.
Okay, well, thank you very much.
Thanks a lot.